In this room, the presentation is entitled Broadening Nurse Influence Through Nurses Serving on Boards. The Institute of Medicine, IOM, published a landmark white paper entitled The Future of Nursing, Leading Change, Advancing Health in 2010. This paper identified a critical lack of professional nurse voices in the boardroom, specifically in the creation and establishment of healthcare policy. And the graduate students presenting are Allison Gulden and Fern Dino. Advisor is Dr. Jenny Prochnow, and community partner was Karen McDonald. I am going to stop sharing and pass it on over to the presenters.
Well, thank you for joining us today. We are excited to talk to you and share with you what we've been doing in our DNP program through the PLI track with Dr. Jenny Prochnow. And we've been focused on broadening the impact of nurses by having them serve on boards. And this all began, this whole focus, it's something that's been around for a while, but hasn't gotten a lot of traction here in Minnesota. It began in 2010 when the Institute of Medicine published a landmark white paper that was entitled The Future of Nursing, Leading Change and Advancing Health. In this paper, the IOM identified a critical lack of professional nurse involvement when it came to the establishment of healthcare policy across the United States. It was emphasizing the fact that nurse voices are critical to improving determinants of health within communities across the country. And for that reason, the Robert Wood Johnson Foundation got interested in this and involved and teamed with AARP, and together they established the Campaign for Action in 2014 with the sole focus of addressing this issue. Then along those lines, the Nurses on Boards Coalition was formed at a national level, and they became a national partner in this Campaign for Action. They went on to further define the goal and set a goal of seating 10,000 professional nurses on boards across America by the end of 2020. So our purpose was to look at what had been happening in Minnesota, and there had been multiple excellent efforts to get this forward in Minnesota, but it's time consuming and very labor intensive, and there had not been a home for it per se that was continuous. Dr. Prochnow has been one of the greatest advocates, along with our mentor, Karen McDonald, of getting this forward. And so it seemed a great opportunity to improve outcomes in the state, in the country, and to help grow our nurses. So as part of our DNP project, we formalized a campaign and we entitled it Nurses on Boards Minnesota, to keep it simple and obvious about what it was that we were doing. And our goal was to align resources that were able to drive education for nurses, provide training for nurses that are interested in board service, and then by virtue of that, support the placement of nurses on boards within the state. When we began our project, we were looking at different models of research and innovation, and we were informed by the Ottawa model that really focuses on practice changes to improve outcomes. And we liked it because it was recommended for neophyte researchers. And we'd never really done anything like this. We ultimately switched and kind of hung our hat on the Paris model, which really focuses on, evidence, context, and facilitation, which they all do to some point. But it really focused on the research and the practitioner experience within the population where the change was going to be translated. And because of this, and because we knew that the context held nurse leaders with a passion for this work, but needed help and support to get it forward, the relevance and the context worked really well for our project. So from there, we identified three main objectives. And our first objective was to identify nurses that were maybe already seated on boards that weren't counted in the national count for Minnesota, and to improve by virtue of getting these people on boards and determining who else might want to be on boards, we were trying to work toward supporting the improvement of health determinants at our state level. And we initially indicated a goal of seating 220 nurses on boards within Minnesota between those that were already serving and new ones to come by the end of March of 2020. The second objective was to identify perceived barriers to board service as reported by the nurses in Minnesota that were caucused. This data was then used to create an interventional toolkit designed to address those specific barriers cited. And then our third objective was to identify existing board members that would be willing to serve as mentors to new board members or people that had an interest in board service but didn't know a lot about it. And to identify, in addition, people that were interested in serving on a board to work with those mentors. So we had multiple layers that we were working with, all with one ultimate objective, which was to increase the nurses on boards here and add to the count across the United States. So it was a very synergistic effort between us as the local Minnesota team, working with the national team independently, but then collaboratively as well. We wanted to accomplish this work and harness the wisdom and the help of nurse leaders within the corporate sector, within the healthcare sector, and within the education sector. And we were very successful in getting people interested and involved on those levels, which helped drive this forward. Fern, I'll turn it over to you to talk about materials and methods.
Okay. Hi, I'm Fern. And one of the things that we found challenging was when we were doing our literature search was the lack of ability to identify a lot of research with statistical data embedded within it on the impact nurses could make because nurses are not readily identifiable on boards. And that created some challenges for us. We went and looked at literature related to women on boards, and Seto Pamies explored some of the relationship with women directors in the European Union and found that corporate social responsibility was positively associated with boards where women were present, with a p-value of 0.029. And Post and Byron reported board performance improvements when women were involved related to financial decisions, as evidenced by higher accounting returns. And Polifrani, Leibel, and McGrath identified the knowledge of nurses that they possess regarding healthcare needs, evidence-based practice, quality and safety issues, and innovations being key in establishing that healthcare policy, which really would promote the social determinants of health and improvement in health on community level as well as the national level. Our study was a mixed method design and we used marketing tools to promote the work of the Nurses on Boards Coalition and Nurses on Boards Minnesota. And our target recipients were nurse leaders to emphasize the importance of board service. We targeted nurse educators as well as nurse leaders. Data from the pre and post intervention survey were used to identify perceived barriers, develop an educational toolkit, and determine the efficacy of that toolkit. And a board member, as Allison noted, was sent to identify potential board mentors. We used a phased approach to survey the nurses, deploy the tools to support the nurses and toward their board service. So we're trying to really target nurses to move towards board service. We evaluated the impact of the interventional toolkit using a post-intervention resurvey to the same recipients. At the project onset, there were 187 Minnesota nurses seated on boards. And as of this month, there are 223 Minnesota nurses seated on boards. So we've reached our goal and exceeded our goal. The pre and post intervention survey was sent to 251 nurses that were interested in board service. In the pre-intervention, 10 of those emails were undeliverable and 11 were undeliverable in the post-intervention phase. There were 46 responses in the pre-intervention and 29 responses in the post-intervention. And there were identical surveys with 8 questions that had a value of 5 points each, with an overall response value of 40 points. The average score for the pre-intervention survey was 33.1, and the post-intervention was 32.7, with an overall decrease of 0.4 points from pre to post survey. When we analyzed these results using a 2-sample t-test of the difference, they were not statistically significant at a 0.05 significance level. There was a decrease in the average responses to questions 1, 3, 4, and 5, and an increase in questions 2, 6, 7, and 8. However, they were not statistically significant. The post-intervention responses demonstrated a decreased confidence level in working in inter-industry teams, planning and leading organizational change, making policy recommendations, and a decrease in knowledge of strategic planning. But the responses to questions 6, 7, and 8 did indicate an increased interest in board service, increased confidence and preparedness to serve on boards, increased understanding of organizational financial statements, and increased understanding of organizational fundraising activities. The greatest change was a decreased level of confidence in making recommendations to healthcare policy, which was question 5 on the survey, and the p-value for that was 0.136. And as you will note in the graphic that's on here, it's very difficult to see, I realize. The range was level 4 to below level 4. So it went from above level 4 down to below level 4. And questions 1, 2, 3, and 6 remained at a level 4 and above, while questions 7 and 8 remained below a level 4. Question 6 related to the level of confidence related to board preparation had the least amount of movement with a p-value of 0.958. When we looked at the board member survey that was sent to 90 nurse leaders seeking to identify interest in being a board mentor, there were 14 responses, and 4 of those members responding indicated an interest in serving in a mentorship capacity. And I'm going to turn it back over to Allison for the implications.
Thank you, Fern. So, and though we did not get statistically significant p-values, there were important appreciable increases for us given our stated goals. We had the 4 data points that Fern referred to that were specific to improving interest and confidence in board service. We saw an overall increase in respondent interest in serving boards as a whole, which mapped to our goal to increase the numbers of nurses on boards in Minnesota. And because of the looming attrition of nurses within the work pool, labor pool, may be interested in being on boards, that is of great significance to us because we're trying to get no more younger people involved. There was an increase in stated confidence and preparedness to serve on boards, which was interesting to us because this was after the interventional toolkit was sent out, given a lot of opportunity to learn and grow. And improved understanding of organizational financial statements and organizational fundraising activities was stated. Both of those were, at the beginning, things that people were stating verbally and in the surveys that they had great anxiety about. Interestingly, the foundational part of the fundraising was the bigger concern, even over and above having the ability to make sense of the financial statements. Of particular interest, like Fern mentioned, we saw the greatest decrease in confidence looking at the pre-intervention survey as compared to the post-intervention survey in respondent confidence, specifically to the ability to make recommendations surrounding healthcare policy, which is the whole goal and objective to seating nurses on these boards. So we've got to wonder if some of the causative factor there for this unknown is potentially related to COVID-19. Healthcare is in such a crisis and leadership is under such fire that it would not be a big leap for us to think that perhaps that had some impact in general to people's sense of confidence in recommending policy, or maybe the belief that the policy changes are just so big that they don't even know where to begin. And I think that's a fair consideration. Our recommendation based on our findings is to consider conducting a repeat survey with a larger participant pool using identical tools and methods, but at a time where we are post-pandemic, where we can potentially get a clearer sense of what's impacting this. We would probably add some data, potentially. I'm not sure we will. We've talked about using the same tools, maybe for certainly the same methods, if not the same tools, maybe adding a couple of things about pandemic impact. And then, weighing that against the anecdotal evidence that we've seen the provision of preparatory toolkit for nurses driving a lot of interest in our younger people, and looking at the efficacy that actually increases numbers of nurses on boards, and think it's worthy of repeat study at a future date. And then we have a very small part of our references listed, but they are specific to Nurses on Boards Coalition and the whys and wherefores of it and how people can get involved. So we thought that we would add those to the presentation. So with that, we will take questions.